the different but very effective way of managing ICH. And for this webinar, we have very senior, experienced, and stalwarts of neurosurgery as a panelist. So, respected Dr. Dev Pujari sir, and Dr. Y.R. Yadav sir, and Dr. Pavitra Patnaik from GMC Nagpur. So, here I invite Dr. Rishikesh, Associate Professor of Neurosurgery from JJ Hospitals of Grand Medical College, to tell us on overview of ICH.
Thank you, sir. Thank you for the opportunity to let me speak. So I'll just go through the overview as well as our experience and recent guidelines. So I'll be speaking on intracranial hemorrhage, the overview and recent guidelines of management. So this is the institute where I work as an associate professor in Grand Medical College. So coming to the introduction, intracerebral hemorrhage is defined as an acute and spontaneous bleeding within the brain parenchyma, which can be ICH, which can be IVH or subarachnoid hemorrhage. So it is the third most frequent cause of stroke following cerebral embolism and thrombotic disease. It accounts for almost 12 to 15 cases per 1 lakh population, that is around 10% to 15% of all stroke cases. The incidence is more in Asian countries, maybe environmental factor or genetic factors. So the 30-day mortality for intracerebral hemorrhage is almost 50%, and it increases to 75% when the location is pontine or brainstem. So the incidence of intracerebral hemorrhage increases in individuals older than 55, and it doubles as the age progresses up to age of 80. So coming to the etiology, most common is hypertensive, which we see commonly in our practice. Non-hypertensive bleed can be due to vascular malformation, hemangiomas, bleeding disorders, most commonly seen amyloid angiopathy, trauma, tumor, and drug abuse like amphetamine, cocaine, PPA. The tumors which are associated most commonly with ICH are glioblastoma, lymphoma, METs, meningioma, pituitary tumors, sometimes acoustics, and cerebral astrocytoma. The risk factor for underlying vascular anomalies are age less than 65, female sex, non-smokers, commonly seen in lobar ICH, and patients with intraventricular extension. So this is the chart showing the age distribution. It increases with the age of more than 55 and up to 80. So coming to hypertensive hemorrhage, which accounts for 60 to 70% of the ICH, theoretically it is due to the chronic hypertension, which causes degeneration and fibrinoid necrosis of the small perforating arteries, leading to the rupture. It is from the arterial wall altered by the effects of hypertension. So it may not be necessary that in a bleed due to hypertensive bleed, the BP should be at the malignant ranges. As the BP increases, it might be due to raised ICP that we have to guess, and acute fluctuations in blood pressure and flow and chronic degenerative changes due to chronic hypertension are most common cause of hypertensive bleed rather than the acute raised malignant hypertension. Most common location is putamen and internal capsule, followed by thalamus, and then lobar locations. The second most common is amyloid angiopathy, especially seen in elderly population. It is due to deposition of amyloid beta peptide in small and medium-sized blood vessel. It results in fibrinoid necrosis and microaneurysm formation. It accounts for almost 9% between the age of 60 to 69 and 58% when the age is more than 90. So multiple nearly simultaneous intracerebral hemorrhages raise the possibility of amyloid angiopathy or bleeding diastasis. Bleeding diastasis, most consistent risk factor for intracranial bleed, is prolonged INR beyond the therapeutic range. These hemorrhages usually develop gradually and insidiously, and the hematoma keeps on growing greater in patients with oral anticoagulant, and you have to be suspicious that this hematoma will keep on increasing, so early intervention might be necessary. The cerebellum and cerebellar lobes are more frequently involved in anticoagulant-induced bleed as compared to hypertensive. So they have a high morbidity and mortality rate. And the important factor in managing these patients is timing of reinstituting the anticoagulant, which has to be gauged by the treating physician, as you have to base the risk factor of recurrent embolization compared with the early risk of bleeding in these patients. So there was not much of a difference between early reinstitution or delayed reinstitution. So it has to be gauged by the treating physician. Drugs related, a variety of abusing substances can cause ICH, and it is to be suspected when the patient is young and normotensive. And these hemorrhages develop within few minutes of drug abuse. The most frequent presenting symptom in these patients is headache, confusion, and seizures. So the pathophysiology to be understood in managing the hypertensive or any spontaneous ICH is the primary effect and the secondary effect. The primary effect is due to growth of the hematoma leading to raised ICP, and secondary effect on the brain is due to downstream effect is due to edema leading to ischemia around the hematoma, and third is progression of hematoma. So this is a chart which has been given. So how it affects. So hematoma expansion leads to tissue disruption, mass effect, raise ICP, which further decreases the blood flow, leading to herniation, leading to ischemia, which leads to blood-brain barrier breakdown, edema, and neuronal damage. So this is the primary brain damage. The secondary brain damage is because of the release of products like thrombin and erythrocyte lysis and hemoglobin, which deteriorates into heme and iron, and this leads to inflammatory reaction, again leading to BBB breakdown, edema, and neuronal damage. So the clinical features, the patient will present most commonly with altered consciousness, nausea, vomiting, headache, seizures, and focal neurological deficit. Headache was much more frequently seen with larger hematoma and very often absent in small or moderate size hematoma. Headache is most commonly seen with lobar or cerebellar hematomas, locations near the meningeal surface, leading to meningeal signs. Patients with small or deep hematomas were never seen with headache. The decreased level of consciousness usually accompanies large hematomas and especially the locations of brainstem. Diminished altered sensorium in patients with ICH is caused by mass effect and raised ICP or direct involvement of brainstem. So decreased level of consciousness has been found to be important adverse prognostic sign. Vomiting can be seen, and in posterior circulation, vomiting reflects the dysfunction of vestibular nuclei or so-called vomiting center. Patient with cerebral hemorrhage almost always vomit early in the clinical course. Some patients with lobar hemorrhages can present with seizures. Other signs which can be seen are neck stiffness, fever, subhyaloid retinal hemorrhage, cardiac arrhythmias, and pulmonary edema. So the key points for localization of the bleed are motor signs, pupillary function, extraocular movements, and gait anomalies. So depending on the location, there can be various presentations like the bleeds in the lateral basal ganglia, putamen, and internal capsule, which are most common, usually due to largest of the lateral lenticular striate arteries. And these patients usually will be presenting with contralateral hemiparesis, contralateral hemisensory loss, conjugate deviation of eyes. The pupils are usually normal in size and gait is hemiparetic. Large putamen hemorrhages can present with stupor or horizontal gaze palsy. So this is the most common location for hypertensive bleeding. So the lesions affecting the anterior limb of internal capsule or anterior putamen can have a transient hemiparesis without sensory anomalies. The posterior one-third of the internal capsule can present with sensory anomalies predominating with or without hemiparesis. Patient with far posterior left putamen bleeds can be presenting with fluent or wernicke's like aphasia. Caudate hemorrhage, which account for 7% of these. So these patiently frequently have a tendency of immediate decompensation into the ventricles. So they can have an early ventricular dilatation and presenting with headache, vomiting, a decrease in sensorium, and neck stiffness. Sensory findings in these are usually minimal or absent. The usual cause for caudate hemorrhage is hypertension. Thalamic hemorrhage, which are due to rupture of thalamus-converting artery. They usually present with severe sensory loss. If large or moderate size thalamic hemorrhage, which can be pressing on the internal capsule, can also sometimes present with hemiplegia or hemiparesis. The other presentations in thalamic bleed can be fluent aphasia, contralateral neglect, or eye signs. Pontine hemorrhages usually present with deep coma within minutes or locked-in syndrome, decerebrate rigidity. Cerebellar hemorrhages are due to the bleeding from the distal branches of superior cerebellar artery or pica. They present usually with occipital headache, recurrent vomiting, vertigo. The loss of consciousness is usually unusual in these patients. Lobar hemorrhages, bleeding areas specifically in subcortical white matters, can be seen usually with anticoagulation or thrombolytic therapy, acquired coagulopathy, cranial trauma, AV malformations, amyloid angiopathy. So these are usually spherical or ovoid, but few follow the contour of subcortical white matter tracts and take form like a slit. So this is a chart depicting the locations and the presentation. So coming to the imaging, CT scan is superior to MRI in acute patient, acute stuporous patient. It is faster and can detect the early hemorrhage. So especially in IVH, CECT can be useful in AVMs, aneurysms, CT angio. MRI is superior in detecting the underlying structural lesion, and gradient echo MRI is also useful. So different stages of ICH on CT: hyperacute, acute, subacute, and chronic. So these are different stages. And it is important to have a formula for estimating the ICH hematoma, that is ABC. A is the longest axis, B is the longest axis perpendicular to A, and C is the number of slices and slice thickness. Role of DSA is especially important in subarachnoid hemorrhage. When you see abnormal calcification in suspected AVM cases, obvious vascular malformations, bleeding into unusual locations like Sylvian fissure, and there is no obvious cause of bleedings in isolated IVH. So this is the ICH score, which can give us the 30-day mortality. So the score more than 5 is also 100% mortality and decreasing. So its components are Glasgow Coma Scale, ICH volume, IVH presence or not, and age. Secondary deterioration is seen in 25% of the patients within 24 hours. It is usually due to expansion of hematoma in the first 3 hours and increase in cerebral edema in next 48 hours, and late progression of edema seen in 2 to 3 weeks. So outcome mortality rate usually is between 23 to 58% in first 6 months. And it all prognosticating factors are GCS score on admission, hematoma volume, location of bleed, presence of intraventricular hemorrhage, and use of anticoagulant. So coming to the recent guidelines which have been given for managing these ICH by the American Stroke Society, which was published in 2022. So they have given a chart. So in history, we have to see the onset of symptoms. What are the symptoms? What are the vascular risk factors? What are the patient was on any medications? Then cognitive impairment or dementia has to be noted, substance abuse, and other systemic illness. So, summarizing the take-home message from this study was this guideline recommends a development of regional system that provides a initial care of ICH in the capacity where appropriate and rapid transfer to the facilities with neurocritical care and neurosurgical capabilities is there. Hematoma expansion is associated with worse outcome. So the range of neuroimaging markers that along with the clinical markers such as time since the stroke onset, use of antithrombotic agents help in predicting the hematoma expansion. So these neuroimaging markers include the signs detectable by non-contrast CT scan, and it should be widely used. The other is you have to identify the markers for both microvascular and macrovascular hemorrhage pathogenesis. The fourth point which they recommend in the treatment of ICH is when implementing the acute blood pressure lowering agents, treatment regime that limit the blood pressure should be variable and achieve a smooth, sustained blood pressure control rather than sudden taking the BP down. You have to have a smooth and sustained blood pressure control to reduce the hematoma expansion, which yields a better functional outcome. When there is an anticoagulation is being given, it has a highly high mortality and morbidity. So these guidelines have providing the updated recommendation for acute reversal of this anticoagulation depending on which anticoagulant therapy the patient was. Then the other recommendation is that prophylactic corticosteroid or continuous hyperosmolar therapy, which were used in, which have been historically used, appears to have no benefit for the outcome of the patient, whereas use of platelet transfusion outside the settings of emergency, when there is emergency surgery needed or patient has a thrombocytopenia, have a worse outcome when given there is no indication to give. Then minimal invasive approaches for evacuation of ICH and intraventricular hemorrhage compared to medical management alone, have demonstrated to reduce the mortality, especially in cerebral hemorrhage, where immediate surgical evacuation is recommended. And the eighth point, they have suggested decision of when and how to limit the life-sustaining treatments after ICH is a complex and highly dependent on the individual preference. But that doesn't mean you have to stop the medical. What they say is life-sustaining treatment depends on individual preference and the patient preference. But till then, we have to continue the medical and surgical intervention if needed. Rehabilitation and recovery are important determinants of ICH outcome and quality of life. So they have given importance for rehabilitation and recovery of the patient. The timing of rehabilitation, like stretching and functional training, may be considered after 24 hours. Before 24 hours, it is not recommended. It is usually recommended after 24 to 48 hours. And the key, sometimes overlooked part of ICH management is patient's home caregiver. The guideline recommends a psychosocial education, practical support, and training of caregiver to improve the patient's balance and activity. So these are the guidelines given by American Stroke Society. So the management of ICH is basically blood pressure reduction, surgical intervention, anti-edema measures, and reversal of coagulopathy. So blood pressure should not be suddenly taken down. It should be around 140. The anticoagulation INR should be corrected immediately with vitamin K, fresh frozen plasma. The thromboprophylaxis, DVT prophylaxis have to be instituted. Patients with raised ICP, the ICP should be decreased to improve the consciousness. So you can put a EVD or you can put ICP monitors. Fever should be treated, and sugar control should be done properly. Seizures, clinical seizures are frequent with patient with ICH and should be treated. So seizures, new onset, unexplained, abnormal, fluctuating mental status with suspicious seizures, where the EEG is reasonable to diagnose the seizures, then they have recommended to administer the anti-seizure drugs. Without any suspicion of seizure, they have recommended to avoid the anti-seizure drugs. Coming to neuroinvasive monitoring and intracranial pressure and edema treatment, they have recommended ventricular drainage should be performed to reduce the mortality. Corticosteroids should not be administered for treatment of raised ICP. That's what they have recommended. ICP monitoring and treatment definitely reduces the mortality and improves the outcome. They have a class 2 evidence for that. Then early prophylactic hyperosmolar therapy for improving outcome is not well established, and bolus hyperosmolar therapy may be considered transiently to reduce the ICP. Surgical management, the aim of surgical management is to prevent the secondary damage and identify the bleeder and treat it. But you have to be careful in selecting the patients. Patient with massive hematoma, which is rapidly progressing, where the clinical outcome is not good, there is no indication of surgery. Small hematomas don't need surgery. Patients with medium to moderate side hematoma, where the clinical outcome is good, the early intervention is recommended. So, depending on the location, cerebellar or lobar, right pituitary hemorrhage are more accessible for surgical drainage rather than the deeper hemorrhages. Size of hematoma does not by itself solely determine the mass effect. Older patients might have a larger hematomas, but with atrophied brain, they can have without raised ICP. Surgical drainage would be indicated more strongly for lesions with great mass effect and have no spontaneous decompression into the ventricular system. Timing of surgery, early intervention is recommended in cerebellar hemorrhage, brainstem compression, hydrocephalus with intraventricular extension, EVD is recommended. And for patients with a lobar hematoma more than 30 ml, and most patients with ICH, the usefulness of surgery is still uncertain. So there is still the confusion. Nobody knows the ideal time to operate. Early intervention or late intervention, all the randomized control style have still not found much of a difference. So usual criteria for a neurosurgeon to evacuate an intracranial hematoma is deterioration in consciousness, midline shift more than maybe 5 to 8 mm, unilateral disappearance of basal systems. So these are the usual criteria which a neurosurgeon follows. The Stitch 1 trial, which was conducted in 2005, did not show any difference or advantages for surgery versus conservative treatment. The second trial, Stitch 2 trial, which ended in 2013, seemed to have a advantage for surgical evacuation for lobar hematomas, but still not for the deep-sitting hematomas. There is third trial, MISTI trial 3 is currently carried out, but the data is not still out. So the assessment of neurosurgeon is therefore necessary if for patient's clinical condition, if deteriorates or CT shows the shift in midline, then you have to operate the patient. So the recommendation was surgical intervention. They have recommended minimal invasive evacuation for supratentorial bleeds with hematoma less than 30 ml, GCS between 5 to 12. So they have advised intervention with minimal invasive evacuation hematoma with thrombolysis, or to improve the mortality as well as the functional outcome for the patient. For the intraventricular hemorrhage, they have recommended EVD, but when they have conducted a trial, in some trials, when EVD with thrombolysis was given, there was definitely the outcome of mortality improved, but there was not much of a difference in functional outcome of the patient. Uh, Coming to the endoscopic evacuation of intraventricular hemorrhage, the study data is limited, and they have still not found much of a difference in functional or mortality outcome. So only EVD, the better thing is EVD with thrombolysis. That's what they have recommended in this
Dr.
trial.
Rishikesh,
Yes,
sorry
sir.
to disturb. Because of time limitations, I think we'll have to conclude.
Okay. Okay. So I'll just run through, sir. So these are different recommendation they are given for craniectomy, craniotomy, and then reversal of coagulopathy. So I'll just show what we do is we follow a minimal invasive approach. We have developed a sheath for endoscopic evacuation of the IC bleeds. So we do a pre-operative marker CT and intraoperative USG localization, and then with a single burr hole under ultrasound guided localization, we do an endoscopic evacuation. We have stopped doing craniotomies or craniectomies unless the patient deteriorates. So we are following is minimal invasive technique in our department. So this is a post-op scan and a significant improvement at 2 months of follow-up. So take-home message is that ICH is the third most common cause of stroke. The Asian population, age more than 55, and female gender are the risk factors which show high incidence. And early diagnosis and CT imaging helps in prompt treatment and better outcome. GCS less than 9 or hemorrhage more than 3 centimeters have poor prognosis. New medical therapies with warfarin and non-vitamin K antagonists have been developed for treating this. There is aggressive medical management, selection of patient with medium-sized hematoma, and timing of surgery are potentially helpful in saving lives. Thank you, and I invite all of you for neurotrauma from 8th to 10th August in Goa. Thank you. Thank you, sir.
Thank you, Dr. Rishikesh. It was a quite comprehensive talk. And sorry, I had to interrupt you because we have two more talks and we'll have to conclude in the next 40 minutes. So maybe we can have discussion at the end of all the talks. So may I invite Dr. Jitendra Tadgare, Associate Professor of Neurosurgery from the Tamag Institute of Higher Education and Research, Savangi Mege Varda. He is going to talk on endoscope assisted evacuation of ICH. Jitendra, to you.
Before that, we appreciate the presence of senior people
Yeah.
today. That is Dr. Dilip Kiawat, Dr. Harshad Parekh sir. We also have Shiv Shankar with us. We have Chaudhary sir, who is right now chairman of our webinar committee. We have Ranjit Deshmukh sir with us right now. And definitely we have Varnan sir. Varnan sir has also joined. Thank you.
Oh,
Thank
that's
you,
great.
everyone.
And I welcome Dr. S.N. Madharia, sir. He has also joined. So
Yeah,
he'll be the next speaker.
Thank you. Jitendra, please continue.
good evening, everyone. And I thank MCNS webinar committee for giving me an opportunity to present my work in this webinar. And it is very good to see my teacher, Dr. Dev Pujari sir, under whom I work for endoscopy.
Jitendra, can you share
Great.
your screen?
आई जाना प्लीज
Am I audible?
नहीं नहीं
Yeah,
ऐसा
you're audible.
नहीं
Your screen
Yes,
is
sir.
not visible.
Is it audible?
Yeah, can see your screen is, you can open that PPT.
Okay. So good evening, everyone. Today I'm going to present my endoscopic work of hematoma
No,
evacuation.
Jitendra, your screen is not visible. Your PPT, PowerPoint is not open.
Now, is it able to see, sir?
No, you are sharing your screen only at the, it is just showing files. You have to click on the file which you want to open.
Hey, you have to
Like
open
this.
the PPT into slideshow and then share the slideshow, Jitendra.
Yeah, now you can
Now go
open
on the
and
slide.
share.
Slideshow.
Can you see, sir?
Yes,
Yeah,
please go.
yeah, Jitendra, you're telling something about Dev Pujari sir. Sir is here.
So, are you able to see my screen now?
Yeah, you can play. You can convert it into slideshow.
Yeah, I have put it in a
Okay.
slideshow
Yeah.
also.
Okay. Go ahead.
Okay. Is everyone able to see my screen now?
Yes, yes, it is
Okay.
seen.
Okay, sir. I just wanted to be Dr. Devpai sir, under whom I work for endoscopic work, and he taught me so many things regarding endoscopy when I was for fellowship under him at Bombay Hospital. So, good evening, sir, and good evening, everyone. Today, I'm going to talk on endoscopic assisted evacuation of spontaneous hypertensive intracerebral hematoma. How I do it. Can you see my next slide, sir?
Yes, yes.
Okay. So spontaneous hypertensive intracerebral hemorrhage is the second most common cause of stroke, accounting for around 7.5 to 30% of all stroke. Hemorrhagic stroke is generally associated with higher morbidity and mortality rates than ischemic stroke. Only one-fifth of the patients regain functional independence after gangliocapsular hemorrhage, and between one-fourth to half of the patients succumb to the bleed. So conservative treatment is indicated when ICH volume is less than 30 ml, regardless of the Glasgow Coma score, whereas surgery may be recommended as a life-saving measure when the ICH volume is more than 30 ml, and we have to correlate it. We have to correlate with the clinical condition of the patient also. Although there are controversies about the optimal management of spontaneous intracerebral hemorrhage, benefits of endoscopic procedure in the ICH have been reported in the literature. So we operate the patient who are presented to the emergency department with CT or MRI scan with evidence of spontaneous hypertensive intracerebral hemorrhage. Patient with post-traumatic hematomas, intracerebral space occupying lesions with bleeds, hemorrhagic transformation of an ischemic stroke, vascular malformation, and aneurysms were not included. So this is our endoscope system. We use a 0-degree rigid scope, 30 centimeter long, 4 mm diameter, Karl Storz Germany scope, and I use it as a freehand technique. Hello, are you able to see my screen, sir?
Yes, we can see.
Okay. So we use a microscope, Carl Zeiss Kinevo 900, for hemostasis of bleeding point if we found and unable to control it using endoscope. Then we use a microscope in between. So we will discuss the one case. 52-year-old male with hypertensive right GC bleed, intubated with midline shift of 1.2 centimeter, was presented to the emergency. So we took the patient for the OT immediately, and we could see the position of the patient supine with head turned with bolster under the shoulder, and we mark 5 centimeter of skin incision just around the coronal suture. So sometimes we shave head, or we can do hair sparing incision also. So this is the after betadine wrapping, painting and wrapping. We keep this setup like this, where endoscope is towards the foot end, microscope trolley, endoscope trolley is towards the foot end. So we take a 5 centimeter skin incision and retract the skin and subgilial tissue using single retractor. Make a single burrow of 8 mm or 6 mm and do a mini keratomy of around 2.5 centimeter. Then dura is exposed. We open the dura cruciately and retract it using silk. So Sometimes I go transcercal, but during the transcercal approach, I found that some minor vessels are injured. So I prefer to go transcortical. And after going deep inside the cortex, when we reach the blood, we stop there and apply a LILA detector system there, and with minimal detection of LILA, so that I can insert a endoscope inside and another suction inside. So only that much of detection I do using LILA detector, and I insert the endoscope inside. So LILA detection system, and I evacuate hematoma some part so that I can put the endoscope inside the cavity. Then insertion of the scope, then inspection of the hematoma, and I go on sucking the hematoma without damaging the adjacent parenchyma. And I also use intermittent saline irrigation. And after evacuation of the hematoma from all the corners, I put Surgicel as a hemostat material and come out. So this is the setup that we. So in between, I had to take microscope to control the bleeding also. So hemostasis is kept material, and coagulation of bleeding point by is done by using microscope. So after achieving a hemostasis internally and evacuating the hematoma, I kept Surgicel at the opening of the cortex, and we can see it is not more than 1 centimeter of corticotomy. So we can see in the last image, uh, distance between the parenchyma is more relaxed. So we close the dura watertight and keep an Abgel. Uh, Fix the bone using a mini clip and keep bone dust around it. And closure of the skin is done in 3 layers. And we can see 5 centimeter skin incision. So I would like to show the video. So as soon as I keep the LILA detector, I insert the scope inside along with the suction with the low suction power, and I handle the hematoma only without damaging the adjacent parenchyma and with minimal detection on the brain surface. So go on evacuating the hematoma inside. So after evacuating the hematoma at the central part, I go at other frontal corners and then temporal corner and then occipital area. So we have to suck blood, and you have to use intermittent irrigation also in between so that our field is clear. So we have to adjust the suction pressure also in between so that it should not suck the parenchyma. So sometimes we have to use the more pressure to suck the hard hematoma, and for the fluid type of liquid hematoma, we can use a small suction, low power suction. So I use freehand technique only. We can see we have evacuated the one corner of the one corner. So we are approaching another corner of the cavity, and we give intermittent irrigation inside. Then this is the last corner towards occipital area. We have to keep take care that we do not suck the parenchyma. So after achieving, we can see the hematoma is completely evacuated. The left side is the frontal area and the right side is the occipital area. And we give intermittent irrigation for some time so that the field is more clear and there is no active bleeding, and we check for any active bleeding during saline irrigation. So no active bleeding is seen after saline irrigation. We keep a hemostat material as surgical inside the C2, and we can see the subdural space. It's quite vein is so lax and there's no active bleeding inside. This is the post-op scan of the patient. We can compare pre-op scan and post-op scan. A small keratomy of only 2 centimeters is enough for this procedure. Then patient during discharge, we repeated the CT scan. We can see the brain is lax, hematoma is also resolved completely, whatever the remaining was there. Patient is discharged with a very small skin incision. Another patient, right side gangliocapsular bleed with 1 centimeter of midline shift. A small keratomy over the cranial area, coronal suture. Post-op 12, the hematoma is resolved, brain is much lax. Before discharge at 12 day, post-op day. Another case of MRI presented with the right side large GC bleed. The post-op scan, small keratomy. Yeah, we also operated one more patient with intraventricular extension. So I had kept an EVD in the ventricle. Then after EVD removal, we can see another patient of left side GC bleed. Another one right side. And this was the case which was already operated for left side decompressive craniotomy, had presented with the rebleeding on the right side. So we operated this patient using endoscope, and we can see we avoided the another side of decompressive craniotomy in this case using endoscope. So endoscopic assisted evacuation has many advantages. So minimal post-op morbidity and mortality, minimal post-op complications, minimal infection, small skin incision, minimal blood loss, minimal surgery duration, short ICU stay, early recovery and out-of-bed mobilization, small craniotomy size, small corticotomy size, no future need for second surgery like cranioplasty, and no foreign body reaction, no flap rejection, no future implant surgery, no cosmetic problems. So natural healing of the bone flap is done when we use bone dust. So endoscopic advantages are internal panoramic view, identifying bleeding point and proper hemostasis of it, removal of the blood clot from all the corners, proper lighting intraoperatively within the cavity, minimal brain handling and tissue damage. So we operated 130 patients in the last 3 years, and out of that, 63 patients were discharged at 12 to 18 days, 38 patients took 18 to 24 days, and 11 patients took more than 24 days, and 28 patients succumbed to the disease. So endoscopic evaluation of intracerebral hematoma is an excellent minimal invasive technique for the treatment of spontaneous hypertensive intracerebral hemorrhage. This approach has the advantage of minimal iatrogenic trauma to the brain with panoramic view, with several added advantages as compared to the decompressive cranectomy, all of which make this procedure easy. All of which makes this technique easy to promote and implement in dedicated primary hospitals having well-equipped neurosurgery operation theaters. Thank you, sir.
Yeah. Thank you, Jitendra. It was a nice presentation. We can have discussion at the end of all the talks. So may I invite Dr. S.N. Madaria, sir? He is a senior consultant neurosurgeon from Raipur. He is a director of neurosurgery at Care Hospital, Raipur. Sir,
Good evening, Yadav
good
Sahab,
evening, sir.
Devdaji sir, and all my seniors and friends. I am sitting in a hotel reception. I came here in Gujarat, and I tried to connect from my room, but not able to connect it. So I am connected at reception only. I am sharing my. Just
I think Dr. Jitendra has to stop.
He has to stop sharing.
Please stop sharing and then, yes.
Yes, Yadav sir.
Yes, sir. can share now, Madhurya.
Yes, yes. Are you able to see it?
नहीं.
Oh,
Go to the green signal.
yeah. This, then
Then share and open your folder.
choose what? It's not able to share it. Some problem in.
नहीं, वो स्टॉप शेयरिंग नहीं करो, शेयर करो और फिर वो फोल्डर ओपन करो. यू हैव स्टार्ट यू शेयर. ऑलराइट, ग्रीन है ना बटन, उसको शेयर करो, फिर अपना पीपीटी खोलो.
आपका लैपटॉप खुला है?
हाँ, लैपटॉप चल रहा है एवरी.
हाँ, तो आप जूम पे हैं तो शेयर बटन दबाइए.
सर ये शेयर बटन है.
ग्रीन है ना, ग्रीन दबाओ. हाँ,
हाँ, उसके बाद समथिंग कमिंग इन
आपके फोल्डर पे जाइए.
रुका, फोल्डर आएगा.
दिस इज माय प्रेजेंटेशन बट
शेयर पे आपका स्क्रीन तो दिखना चाहिए, जो भी है. शेयर नहीं हो रहा है.
शेयर नहीं होता है. फुल स्क्रीन एबल टू सी इट बट
एक बार शेयर हुआ था, फिर आपने ना उसको स्टॉप शेयर कर दिया. अब हुआ है. स्टॉप पे मत करो. हाँ, अब आपका वो PPT खोलो.
नो इट इज नॉट कमिंग एट ऑल. सॉरी, आई एम नॉट एबल टू
आप
कनेक्ट.
फिर से एक बार कीजिए, शेयर कीजिए.
This screen is coming, but beyond that it is not coming.
नहीं, शेयर तो कीजिए.
शेयर हुआ. हाँ,
अभी उसका पहला ऑप्शन क्या है, आप दूसरे ऑप्शन पे जा रहे हैं.
ये
फिर हट गया.
अच्छा, फिर आप बोल दीजिए क्या करते हैं.
sorry, not able to share. नहीं,
You can tell us what you do and what you think is the new thing in that. Without slides बता पाएंगे? Or maybe he does not have the bandwidth.
नेट की प्रॉब्लम होगी. नेट.
We can start the discussion and then maybe whenever he is ready, we can let him present.
Okay, right, sir. So, thanks, Dr. Rishikesh and Jitendra, for wonderful talk. And in today's era of endoscopic or endoscope-assisted evacuation of ICH, actually we have two masters of endoscopy. So before we proceed, can we request Yadav sir to talk on his opinion, sir?
Okay, thank you. Thank you, MCNS and Dr. Sandeep for giving me this opportunity. I think I'll share my views on, the summary.
just
Just 3 minutes. Uh,
जैसे ये
नहीं यहाँ पे विंडो में आपका को वीडियो है या पीडीएफ है?
PDF है.
see the slide. Can you see slide?
Yeah.
तो
Yes, sir.
Okay. So I would like to thank the MCNS Dr. for giving me this opportunity, and also congratulate all the speakers for their excellent presentation. These were really very good. And
ये
I'm
बात.
sure we will listen from Dr. Materia to talk. This slide completes this of the question, including.
Sir, your audio is not clear.
Okay.
Now it's better.
Okay. So we are comparing, this slide compares the various technique, including mini craniotomy with or without tubular retractor, minimally invasive aspiration and thrombolysis, which Dr. Maderia will talk, and channel endoscopic surgery and tubular retractor endoscopic surgery. So these are the surgical technique. Although I have experience in mini craniotomy and channel endoscopic surgery and tubular retractor surgery in ICH, the comparison of missed thrombolysis is based on literature review only, as I do not have personal experience of this technique. This slide, there is a green color which highlights the advantage of techniques, different technique, 4 technique which are given, and the red indicates the limitations. So among these, you can see that the endoscopic approaches, particularly the tubular retractor assisted surgery, has the most balanced advantage. The mini craniotomy is effective for rapid clot removal and is suitable for large hematoma, but it is more invasive and offers limited visualization, especially of the corner, and it may increase the risk of brain edema and the injury. Whereas missed thrombolysis is the least invasive technique, but it does not provide direct visualization. So it's a blind technique and requires multiple sessions over the days for effective clot removal. So in day 1, you cannot remove the whole clot. So for some time you need, and it is generally unsuitable for large and mixed density hematoma. So any hematoma which has a risk of rebleeding, like those with the spot sign or with dot sign, where the chances of rebleed are high, such technique should not be done. It also carries increased risk of rebleeding and infection, especially if the clot is firm, and in case where there is a spot sign, where there is increased risk of rebleeding. Whereas channel endoscopic surgery provides, that means the endoscopic surgery in which the instruments are passed through the working channel, provides direct visualization, and there is a rapid clot evacuation, unlike thrombolysis or aspiration technique, and it can be used for large hematomas. However, because of limited bimanual dissection, there is a difficulty in intraoperative bleeding control, and there is also difficulty in removal of firm hematoma. So these are 2 limitations of channel endoscopic surgery: the difficult bimanual dissection, and if there is a firm hematoma, then under usual condition, the technique cannot be performed. Although people have specialized instrument like CUSA, which can be passed through the working channel, or they have suction coagulation instrument in which suction has coagulation only. So in those cases, they can do it. But under general condition, these are the limitation of channel endoscopic surgery. The tubular retractor assisted surgery offers the minimally invasive, excellent visualization, and it is effective for clot removal. even in the firm and high risk cases where there's a risk of bleeding. So for these cases, it is an excellent technique. The further analysis of this technique, while mini craniotomy is a straightforward procedure, and it is associated with longer ICU and hospital stay, the control trial, the stage 1 and stage 2 have not demonstrated any clear superiority of this technique over the conservative treatment. The missed thrombolysis is a relative simple procedure and have shown improved outcome for small to medium sized hematomas. So only for a small and medium sized hematoma you can do it. If the hematoma is very large, I think it is difficult because it takes more time. So by the time you remove significant hematoma, the damage is already done. But it requires prolonged drainage and carries a high risk of infection. The channel endoscopic surgery offers a high clot removal rate right from the surgery itself, day one, and offers the favorable outcome in recent studies. So recent studies have shown that endoscope has a better outcome compared to conservative treatment. However, it is less effective when the clot is firm, and it requires an experienced endoscopic surgeon, and involves the another disadvantage is that it involves high initial cost, though the cost becomes later on it becomes a cost effective over the time period. The tubular retractor assisted endoscopic surgery is most effective even for the firm clot and even when there's a active bleeding going on, because you can use 2 instrument or 3 instrument through the tubular retractor and good bimanual control is possible. But the disadvantage is that you require expert surgeon and there's a high upfront investment, but it ultimately proves to be cost effective in long run. So to conclude, this slide concludes the surgical indication for, the technique for various technique for ICH. The mini craniotomy is typically used when endoscopic facilities are not available, especially when the hematoma is large and when it is firm and the case where there is a high risk of bleeding. So you can imagine that these cases are not suitable for thrombolysis when there's a firm clot and when there's a risk of bleeding, because you cannot control bleeding in thrombolysis. Rather, there's a high risk of rebleeding. Missed thrombolysis is suitable for medium-sized clot patient without access to the endoscopic surgery, so where you don't have facilities for endoscopy, but is less effective for firm clot and in cases where there is a high risk of bleeding. Channel endoscopy is appropriate for hematoma, most of the hematoma, except when the clot is firm and when you have high risk of bleeding, like you have a spot sign or dot sign or a hematoma irregular with satellite hematoma. But you require experienced endoscopic surgery. So these limitations of endoscopy can be, channel endoscopy can be overcome if you have CUSA or you have suction coagulation system, which can be passed through the endoscopic channel. Whereas on the other hand, tubular retractor surgery can be done by anyone, because with the simple instrument through the tube and with the endoscope, you can remove all the clot and you can achieve hemostasis. You can remove even the firm hematoma, and actively bleeding can also be controlled. So that is my opinion, but I want to say that I have no experience on thrombolysis. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you.
So we have some questions in our chat system, and the major question comes from Dr. Kishore Chaudhary. Sir, Kishore sir, your opinion, please.
Sorry, I'll come back to you.
Yes, sir.
We'll
Yeah.
discuss all
Sir,
this.
if Dr. S.N. Mother is ready, can we have his talk and then we can
Let's
discuss?
discuss it out this time, Sandeep.
Okay. Okay.
Yeah, again we will keep it. Okay. Already we have crossed 9:30. Okay.
Oh.
Yeah.
But Madhurya sir, is there any issues with connection now? So you're muted.
What I am doing is just making a burr hole. Hello, I'm audible?
Yes.
Hello, Sandeep.
Sir,
Yes, sir.
I
Yes.
think that without sharing his screen or without his
yes.
presentation, already there are expert opinion on the management of ICH by Dr. Yadav sir, and
Yes,
he
sir.
has discussed out in details all the indications.
Right.
We will take Dr. Madharia sir's lecture in next sitting.
Okay.
Right now, we should take the opinion of the other panelists.
Okay.
What I feel is that.
Can I make some comments then?
Yes, sir, definitely.
So I think I
Yeah.
would start from the first talk. I think Rishikesh has given a good overview, but as you have seen, most of the figures he put are all Western hemisphere figures, mostly American figures. I think the ICMR has data now available, and there are some guidelines. We have a slightly higher risk of ICH as a cause of stroke compared to ischemic strokes, mainly because of increased risk of hypertension. I think that is the major issue. The second issue I would like to talk about is you talked about anticoagulants. I think the picture has changed so dramatically over the last 10 years, and I'm sure you are more aware of this than me, that most patients are not on warfarin. They are on what are called as low molecular weight heparin analogs or Brilanta or some stuff like that, for which there is hardly any, antidote available there. They are becoming available slowly. They are expensive and they are not as reliable. So I think that is another thing which you have to keep in mind. So these were the two main things. And before you mentioned most of the trials have been done in Britain, because I think they are very, very cost conscious as to when to operate, when not to operate, and what to show and what not to show. And fortunately, Dr. Mendelo, who conducted both the Stitch trials, was one of my teachers or senior colleagues. And I have been associated with at least the first to some extent, and we have no definite criteria as to when to operate and how to operate. I think that is very clear. The trial which was done much earlier than that, which your generation obviously does not know, is the trial done by Wiley McKissock, and that was done in London, and that was done before the days of CT scan, so it was not given so much importance. But he had also, I mean, earlier angiography and other things were there to see if it was a lobar or a basal ganglia hematoma. And Dr. Bhagwati was working with him, so we always used to hear from him what the outcome was. And again, they had not been able to show any improvement in outcome with any kind of surgery. So we have come with a background without any definite evidence that surgery helps. So now I think Dr. Kishore Chaudhary has raised a very good question as to when do you really advise surgery? And I think that you have shown very nicely in your guidelines. But I would like to hear his comments. I won't go on that issue. In terms of using endoscope or minimally invasive or any other techniques, I think one thing which is very clear from this webinar, and I think all youngsters should be listening to this, there is a huge tendency at the periphery to do a large craniotomy, may or may not remove the clot, and just take the bone flap out. I think that treatment not only everybody not recommends, nobody even mentions about it. So I think you have to get that out of your head. It is the raised ICP, as Rishikesh has said, because of the age and various other factors, may be a factor, but I think local pressure is the more factor. And local pressure and the toxic effect of blood has been one of the main reasons why the Japanese wanted ultra early surgery. So that if we remove that, then the edema will become less, etc. and then the minimally invasive approaches started. I think I would not go too much in detail because we have very little time, but it seems that uh, I'm definitely sure, Dr. Yadav, that endoscopic or endoscope assisted minimally invasive approaches have proved better than the traditional approaches earlier. But have they fared better than conservative approach? That I do not know, because we do not have patients who can be compared like that. So that is something which I do not definitely know, and I would like to hear the comments from others.
I mean, not trials, and which trial is going on that will answer this question. But there are big studies which show that endoscopic surgery has a better outcome than the conservative treatment. Earlier stitch trial, the results were not good. The people have, even Professor Mandelo has advised that the advantage of surgery is possibly, taken away by the more invasive approach in the conventional craniotomy.
Oh yes, we are talking of equivocal cases. I mean, there are patients who definitely require surgery, and there are patients who may not be helped by surgery. So we are talking of that group. You are
Lobar
right.
hematoma, sir, even these people said it is even for deep-seated hematomas, the endoscopic treatment have shown benefit in the recent big case studies, not the trials. Trial is going on, and its trial, I think it started in 24. I think we'll get the result in maybe 1 year time or so.
Hello.
Thank you.
In
Sir,
equivocal
Chaudhary sir.
cases. Hello.
Hello.
Chaudhary
Dr.
sir is
Kishore
there?
Chaudhary sir.
Is Dr. Chaudhary ready?
Yes, thank you very much. I've been listening to all the talks. In fact, I have contributed to David Mendelow's both the trials, and I've contributed all my patients for the stage 1 and stage 2 trials. And I think with the time, things have evolved, and this is my gut feeling now. I don't have any proof for it, but I think with the minimalistic endoscopic approaches, maybe we could have a lower threshold for operating those patients. Previously, people used to do big craniotomies, sometimes decompressive craniectomies, large corticotomies, etc. But I think the endoscopic approaches in capable hands, experienced hands, probably might be a bit of game changer. I don't have any proof, but this is my own just an intuition. I did most of the hematomas in our career by an open approach and not endoscopic. But endoscopic becoming more and more popular, more and more trainees are using it, and maybe that would be the best way to go ahead. I think, as Jitendra and Dr. Yadav is saying. As far as the indications for surgery is concerned, I will give you some statistics. I'm sitting in my office on call, and I get 20 patients referred per day with intracerebral hematomas. So in a weeks of my on-call duties, I get about 150 patients of spontaneous intracerebral hemorrhage referred to us. And we hardly operate about less than 5% of them, because most of them are very elderly. Most of them are dominant hemispheric strokes. Most of them, we feel, have enough comorbidities such as kidney failures or whatever, where their ultimate neurological recovery is probably not possible, and they are not going to walk out of the hospital. And we are, as Shekhar mentioned, we are very cost conscious. We depend on the trials, we go by the trials, and we have to have serious indication to defy the guidelines and do the cases. So yes, we are very conservative. And over my 25, 30 years of experience, I think what they practice in Britain is probably right. Because if we follow these patients on for 1 year, 2 years, 5 years, 10 years, 15 years, I'm not sure really that they are able to add any meaningful life to the society and to their families. And I think that factor becomes more relevant in India, where the social security systems are not that well established. So my appeal to everyone is that it's quite good to do good surgery, whether you do open or microscopic or endoscopic, and it's very good to see a good post-operative scan showing hardly any blood there. All applause to this, but I'm not sure really. Many a times, probably we may end up erring towards operating on the patients without any meaningful benefit to the patients in the long term, especially in the elder age group or the dominant side hematomas.
So, Kishore, I think one of the things which you have said is that the social security system or the rehabilitation facilities, specially sponsored by uh, social system or the government, does not unfortunately exist in this country. Uh, but the problem comes is when it comes to taking a consent or explaining to the patient's relatives, the questions asked are very funny. Do you think there is even 1% chance of survival? Do you think he will at least be able to see us? Do you think he will? I mean, if you have a left-sided clot and you tell them that he may not be able to understand anything, it's not worthwhile. So I think we have difficult situations. I have two technical small questions. One is it necessary to remove the clot completely, whichever method you use? And number two is, there is a huge, I mean, there are several people who are talking about working in the long axis of the clot and making boreholes or craniotomy on forehead. What is the what are the panels think about it?
Sir, one comment to make, Depajari sir. As you rightly said that I personally believe that there is no point in going after every single bit of the clot during removal. At times, you can cause more harm by disturbing that clot which has already taken care of the bleeding at that particular point. So we should not be running after a scan which is looking good post-operatively, but it should be a decision which is primarily based during the surgery intraoperatively, where we find that the brain is extremely it is looking good, it is lax, it is pulsatile, and I think then it also depends on many other factors, whether the patient was any anticoagulant therapy, whether there were any uh, other comorbidities, or a patient has got a tendency to bleed. So a lot of factors are there. But then the decision, what I would like to, even suggest, Rishikesh did a fantastic presentation, no doubt about it. But I think all these guidelines and protocols, they are intended to define the practices to improve the quality of care actually. But the actual decision has to be made by the clinician. It has to be made with the experience that each one of us has had in the tenure of neurosurgical practice. And it is that judgment which makes all the difference, whether it is endoscopic, whether it is bimanual microneurosurgery. At the end of everything, the patient should at least, if he does not improve, he should not deteriorate. So this is what I would like to uh, talk on your point, sir.
Just
There are
just
two
going on to
questions
Shekhar's.
in the
Uh,
there are two questions in the chat box. One is timing of surgery for endoscopic evacuation, sir, and whether there is any role of steroids.
No role of steroid. Timing of surgery is as early as possible, but 24 hours to 48 hours is the period. I mean, as early as possible, because if you delay surgery, it causes harm. Regarding how much clot to be removed, I mean, it should be as much as possible. But trials have shown, the series has shown that if you reduce the amount of hematoma to 15 ml or less, then the results are good. So if you leave it more than 50 ml, then obviously possibly you have not done the good job. But chasing every bit of clot may not be required, but it should be 15 ml or less.
And another question is about the longitudinal axis of the hematoma, sir, whether the frontal bone is going to help or something like that.
It should be along the longitudinal axis, even if your craniotomy, so-called mini craniotomy or burr hole, is away from the site of hematoma. The reason is when you use endoscopic surgery, you with very minimal tract, you can take out the whole hematoma. Whereas if you go right angle to the long axis, then you need to retract more of the brain, even if you need, even if you use endoscope. So long axis of clot, near long axis is required, not perpendicular to the long axis. That is not advisable.
And sir, Kishore sir, in
Yeah.
today's era, like we are seeing many patients in 60s and 70s. So what is your cutoff for the elderly people after which you don't offer surgical intervention?
There is no age cutoff. I'll tell you the problem because in our community, even those who are 65, 70 are doing rock climbing. They are on their third or
Yeah,
fourth marriage and they are
that's what.
extremely fit and healthy. So it is very difficult to put an age bar on it. But if they have medical comorbidities or they are on multiple drugs or cardiac failure, renal ailments, or on anticoagulation, then we tend to treat them conservatively. Otherwise, the age as such per se is not, but I have not operated on a hypertensive hematoma more than 75 years old at all, because at the age of say 75 plus, there will be enough space in the cranial cavity to accommodate that. And if the hematoma is so big that it is causing raised ICP in an elderly person, the patient is going to probably die no matter what you do, because it will be far too extensive hematoma. There are two things I always mention to my registrars uh, about the technique. No matter what you practice, number one is whenever you're operating on a hypertensive hematoma, the hemostasis has already been achieved by the nature. So whatever bleeding happens during surgery, you are the one who's causing it. So it is a good idea to just delicately evacuate, lift up the hematoma rather than being very aggressive in the deeper parts. And second thing I always tell is that it would be worthwhile, especially after a couple of days of your if you're operating, to wash out the hematoma and then suck out the washed part rather than actually use sucker very aggressively. One of the most damaging instruments in neurosurgery, in my opinion, is the strong suction. And I think if you are taking care of a couple of things, I think even if we evacuate 75-80% of the hematoma, it should do the job all right.
Right. So one
There is
question
one
to
more
Dev.
question. There is one
Yes,
more
sir.
question, Sandeep.
Yes, sir.
That how many times the endoscopic evacuation after the endoscopic evacuation, the craniotomy is needed because of the edema. So, what is the opinion of the experts on it? We have to take it that how many times we need to convert the endoscopic surgery into open craniotomy after maybe after 24 hours, maybe after 48 hours, due to gross cerebral edema. Is there any criteria for it?
So,
Usually not unless you have damaged a vein or artery.
Sir.
Sir,
Very,
other way.
very rare. Yeah, agree.
can I answer this also,
Yeah,
Sarath?
yeah, sir.
So the answer lies in how much you have. The edema is because of the clot, and
Absolutely.
the edema caused by this. So there is if there is a persistent hematoma, then you have perihematoma edema. So in that case, you may require to do decompression. I have done twice in my career in endoscopic surgery when the hematoma was left out. And the reasons were clear. We removed the superficial hematoma, the deep hematoma was trapped, and we could not remove. So I think, but if you do the job well, the edema part, even if it remains, can be taken care of by the medicines, mannitol and other things. So
Uh,
rarely you need the decompression or craniotomy after doing endoscopic surgery.
so, so Prabodh and myself, we belong to a place where we had been dealing with a lot of patients referred to government setup in a situation when we did not even have CT scan to do post-operatively. So my experience has been like we had been doing large craniotomies and we had been doing corticectomies, small corticectomies, thin corridors, not more than 0.5 centimeters. And then we go into the clot and microneurosurgically, we remove the clot and take the hemostasis as much as possible. The satisfaction that we had was that even if the patient had little recurrence or rebleed, the craniotomy was there to support us overnight or whatever. So this kept on going, and I'll tell you something, sir. The institutional practice sometimes is much different from what the practice is done elsewhere. Like as you said that in the peripheral areas, most of the neurosurgeons they're doing freelancing practice, and it is extremely important for these patients to be managed in a critical care, which is supported by neurophysicians and neurosurgeons and specialist team who's trained to treat these patients. What happens is that these patients are operated elsewhere and then they are kept on ventilator, and then these patients are not sedated properly, and then patients with labile hypertension, uncontrolled hypertension post-operatively, and these patients have tendency to rebleed. And it becomes very difficult to then manage these patients or take the patient again for a redo surgery. So the counseling is extremely important. Managing these patients in a neurocritical care setup is extremely important. So that is what one question was coming to my mind also, that what was the recurrence rate, or what was the redo surgeries, or converting the endoscopic surgeries into craniotomies. So I got your answer now. Thank you.
So to explain on again, I think partly it has been answered by Dr. Kishore Chaudhary also. He said that if you don't have proper facilities, or if you cannot visualize the whole hematoma very well, then it is better to leave little bit of rim with the bleeding at the periphery. The vessels are at the periphery. So if you leave little bit, then usually it works. But if you are working with the endoscope, and if you are an expert endoscopic surgeon, like and now we go for 100% clot removal and do meticulous hemostasis, because if you leave some abnormal vessel there or some oozing, it bleeds. So we have shown in all workshops that absolute hemostasis can be done with endoscopic surgery, and if you do that, and it is essential.
Yes, sir.
So if you do good hemostasis and if you take out the clot very well, but we don't say that you take you operate every case. We don't operate, although the literature says GCS 5 to 13. But we do surgery only in GCS 8 to 13. So any patient who is decerebrating is in bad shape, except when the patient initially was in good GCS and then deteriorated, then we go in. Otherwise, right from day one after the ictus, if the GCS is poor and associated with large hematoma, we don't operate. You don't operate for hematoma which are very small. I don't operate for thalamic hematoma which extends into the brainstem, but we operate basal ganglionic hematoma or even thalamic hematoma which extends into the ventricle. So these are some of the cases, plus brainstem obviously are for surgery. Yeah.
Thank you, sir.
Thank you. I think that Sandeep, there is enough discussion. Varnan sir,
Yes,
are
sir.
you there?
Last one question.
Varnan
Yeah,
sir is
maybe
there?
Varnan sir or any say Dev Pujari sir or Varnan sir can
What is
answer.
the
So
question?
patient is being managed conservatively for 7 to 8 days and then deteriorated, and patient has significant mass effect and midline shift. In such patients, what do you what is your strategy?
Is
Like
Dr.
larger
Velo there?
craniotomy versus
Is
endoscopic
Dr.
or
Varnan there?
Yeah, I'm
yes, sir,
there.
is there.
This
See,
typically happens in 3rd to 5th day. Anyway, please go ahead.
Yeah, see, basically, there are three things which are important for an IC bleed. First is the size of the IC bleed. Number one, the blood pressure, which has to be controlled before you do any intervention, medical or surgical. Okay, and the third is the irritation of the clot, the CC of the clot.
If anything, it is more than 30 ml, it is going to cause problems. If it is less than 30, you can play with it, you can stay with it, and you can observe it. So we are very aggressive because we do not get one case, we get around 10 cases, which we have to see. Every day we are seeing IC bleeds only. So we have to be very quick. And second thing is, you should not be too early and too eager to operate initially. You stabilize the blood pressure. If the patient has even a size which is more than 30 ml, and if the patient is well preserved, don't touch him. You wait and observe the patient. This is what we follow in our strategies. We go basically for basal ganglia bleeds, we go supraorbital. We do a supraorbital incision, make a burrow and go straight down along the linear axis. Another important thing is to have a CT contrast to look for there is a sign which is there, spot sign. If there is a spot sign, this bleed is going to increase. So always do a CT contrast. In all IC bleeds, do a CT contrast. Look for the spot sign. If there is a spot sign, you got to be ready to operate these patients. So we are more aggressive in these patients. We operate and we have got good results. The deficit does not improve. The patients might be hemiplegic, but still they would be alive and they would be even mobile using a walker or using a walker stick. We go endoscopic. We have stopped craniotomies. For hypertensive IC bleeds, it is banned in our department, because we monitor the ICP before evacuation and we monitor the ICP after evacuation. And that is monitored for 72 hours.
Sir, final comment from Devpujari, sir.
The only thing
right-sided and left-sided hematoma, sir.
Pramod was saying about the day. Usually the deterioration occurs between 3rd to 5th day.
After
And earlier it used to be believed it is usually because of the electrolyte disturbance. Most of these patients are on diuretics, etc., etc., and the fluid given. So I think that has to be also, the edema sometimes can be because of inadequate fluid management.
And so there is a question regarding dominant versus non-dominant.
Non-dominant.
It does not make any difference, in my opinion. It depends upon the size of the clot, and you see the spot sign, you don't wait, whether it is dominant or, because there are more chances of recovery if you evacuate. If the patient is symptomatic, the GC is down, you have to evacuate. And endoscopic is much better. Craniotomy is banned, at least in our department.
We also operate on left side, but the recovery is slow. We tell them that this problem may be there. The comprehension also, left side clot is likely to fare less well than the right side. Yes, but we operate them. Yes.
Thank you, everyone.
Pramod, sir, final comment from you.
So now I have learned too many things on this good day, that there are specific indications. Then you have to go for the evacuation. The tubular retractor evacuation by endoscopic method is the best method for right now. Right or left, it doesn't matter. And depending on the expertise of the endoscopy is the best, gives the best chance to the patient. And definitely, I think that we need a little bit of good social security system to manage these patients, because in the private setup, in the OPD, it is very difficult to manage these patients and counsel them regarding their recovery. Many a times the left-sided patients, they demand too many things. Just like Dev Pujari sir said that वो देखेगा क्या, वो समझेगा क्या, उन्होंने आँख खोल दिया तो भी बहुत है. All these patients' relatives, after 6 months, they will blame you that the patient is still not talking, whether what is wrong at that time and all those things. So there are too many things we learned today. It's an excellent, what we say is the webinar, one of the webinars, and well attended also.
Yeah.
Thank you.
So I would like to acknowledge the active participation from the very senior Dev Pujari sir, Yadav sir, Varnan sir, Dr. Kishore Chaudhary sir, and all the panelists, all the speakers. Rishikesh and Jitendra has done fantastic job. Thank you so much for
one word, please.
Sir.
One sentence. I mean, we should not be carried away with the endoscope only. For peripheral people who are working or those who do not have endoscope, see, if you have tubular retractor, with same tubular retractor with microscope you can take out. So endoscope is good, excellent if you have and if you have expertise. But if you don't, then you use possibly I recommend tubular retractor with the microscope. It does reasonably good work except for peripheral visualizers. Thank you.
Very, very good advice, Dr. Yadav.
Yes, sir.
Thank you, sir.
Thank you.
sir. Dr. Sarang, to you.
Thank you, everyone.
Thank you, Sandeep.
Thank you,
Good night.
Sandeep.
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you, Pramod.
Everybody.
Thank you.
Thank you.
Thank you.
Bye, Sarang. Good
Bye,
night.
sir. Bye, sir. Good
I
night,
will
all.
say good night.
Good night.